Basics of Medical Biochemistry. First edition, 2023. Chapter 12. Metabolism of Lipids. Part 3 of 3. By Professor Dr. Muhammad Jawad. MBBS, Tao, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College Air University, PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. Chapter 12. 12.11 Metabolism of Phospholipids. Phospholipids are one of the types of compound lipids, composed of fatty acids, alcohol, and phosphoric acid. These are considered a group of specialized lipids performing a variety of functions, such as involvement in membrane structure and functions, blood clotting, and supply of arachidonic acid for the synthesis of prostaglandins. According to the type of alcohol present, they are further divided into glycerophospholipids and sphingophospholipids. In glycerophospholipids, the alcohol is glycerol, and in sphingophospholipids, the alcohol is sphingosine. 12.11.1 Synthesis of glycerophospholipids. Glycerophospholipids are also known as phosphoglycerides. They are composed of glycerol, fatty acid, and a phosphate group. Sometimes they also contain nitrogenous bases in their molecule. The important glycerophospholipids are phosphatidylcholine, lecithin; phosphatidylethanelamine, cephalin; phosphatidylinositol; phosphatidylserine; diphosphatidylglycerol, cardiolipin; plasmalogen. Phospholipids are considered as derivatives of phosphatidic acid. Structurally, phosphatidic acid is 1,2-diacylglycerol 3-phosphate. It is regarded as a precursor for all glycerophospholipids, see Figure 5.7. 1. Synthesis of phosphatidylcholine, lecithin. Lecithin is synthesized from activated choline and diacylglycerol. Its synthesis involved the following steps. I. Formation of diacylglycerol. Diacylglycerol is derived from phosphatidic acid by the enzyme phosphatase. Phosphatidic acid diacylglycerol plus pi. 2. Formation of phosphocholine. A phosphate group is transferred from ADP to choline to form phosphocholine by the enzyme choline kinase. 3. Formation of CDP-choline. A citidyl group is transferred from CTP to phosphocholine to form CDP-choline. The transfer of the citidyl group is catalyzed by the enzyme CTP-phosphocholine citidyl transferase. CDP-choline acts as an activated form of choline. 4. Formation of lecithin. Phosphocholine is transferred from CDP-choline to diacylglycerol to form lecithin with the release of CMP. This reaction is catalyzed by the enzyme diacylglycerol phosphocholine transferase, CMP, CDP, and CTP equals cytidine mono, D and triphosphate. Figure 12. Synthesis of lecithin. Figure 12.36 Synthesis of phosphatidylcholine or lecithin, CMP, cytidine monophosphate, CTP, cytidine triphosphate, pi, inorganic phosphate, PPI, pyrophosphate. 2. Synthesis of phosphatidylethanelamine, cephalin. Synthesis of phosphatidylethanelamine follows the same steps as for the synthesis of lecithin, utilizing ethanolamine in place of choline. Figure 12.37 Synthesis of phosphatidylethanelamine, cephalin. 3. Synthesis of phosphatidylinositol. Phosphatidylinositol is synthesized from CDP-diacylglycerol and inositol. CDP-diacylglycerol is obtained from the reaction between phosphatidic acid and CTP. CDP-diacylglycerol reacts with inositol to form phosphatidylinositol. Both reactions are catalyzed by the respective transferases. Figure 12.38 Synthesis of phosphatidylinositol. 4. Synthesis of phosphatidylserine. First, CDP-diacylglycerol is obtained from the reaction between phosphatidic acid and CTP. Then, phosphatidylserine is synthesized from CDP-diacylglycerol and serine, an amino acid. CDP-diacylglycerol reacts with serine to form phosphatidylserine. Figure 12.39 Synthesis of phosphatidylserine. 5. Synthesis of cardiolipin. Cardiolipin is diphosphatidylglycerol. It is found only in mitochondria, where it regulates various metabolic processes taking place in mitochondria. It is synthesized from 2 molecules of CDP-diacylglycerol and 1 molecule of glycerol 3-phosphate through the following steps. I. Formation of CDP-diacylglycerol. It is formed by the reaction between phosphatidic acid and CTP catalyzed by the enzyme CDP-diacylglycerol synthase. Figure 12.40 Formation of CDP-diacylglycerol, CDs, CDP-diacylglycerol synthase. 2. Formation of phosphatidylglycerol. It is formed from CDP-diacylglycerol and glycerol 3-phosphate with the intermediate formation of phosphatidylglycerol 3-phosphate. A phosphatidate group is transferred from CDP-diacylglycerol to glycerol 3-phosphate to form phosphatidylglycerol 3-phosphate. The phosphate group is split off from phosphatidylglycerol 3-phosphate to form phosphatidylglycerol. Glycerol 3-phosphate CMPH2O pi. CDP-diacylglycerol phosphatidylglycerol 3-phosphate phosphatidylglycerol. 3. Formation of cardiolipin. Phosphatidylglycerol reacts with another molecule of CDP-diacylglycerol. A phosphatidate group is transferred from CDP-diacylglycerol to phosphatidylglycerol. The product is diphosphatidylglycerol, i.e., cardiolipin, along with the release of CMP. Figure 12.41 Synthesis of cardiolipin, CLS, cardiolipin synthase, CMP, cytidine monophosphate. 6. Synthesis of plasmalogen. These are phospholipids with a fatty acid at carbon number 1 bound by an ether linkage instead of an ester linkage. An important plasmalogen, 1-alkenyl-2-acetylglycerol 3-phosphocholine, causes blood platelet aggregation and is referred to as a platelet activating factor, PAF. Synthesis of plasmalogen involved the following steps. I. Formation of 1-alkyl-glycerol 3-phosphate. The synthesis of plasmalogen started with the addition of a fatty acyl group to C1 of dihydroxyacetone phosphate, DHAP, by the enzyme acyltransferase to produce 1-acyl dihydroxyacetone phosphate. The acyl group is then replaced by an alkyl group to produce 1-alkyl dihydroxyacetone 3-phosphate, which is then reduced to 1-alkyl glycerol 3-phosphate. Figure 12.42 Formation of 1-alkyl glycerol 3-phosphate. 2. Formation of 1-alkyl 2-acylglycerol 3-phosphoethanolamine. An acyl group is transferred from fatty acyl CoA to C2 of 1-alkyl glycerol 3-phosphate. The phosphate at C3 is replaced by phosphoethanolamine to produce 1-alkyl 2-acylglycerol 3-phosphoethanolamine. Figure 12.43 Formation of 1-alkyl 2-acylglycerol 3-phosphoethanolamine. 3. Formation of 1-alkenyl 2-acylglycerol 3-phosphoethanolamine, plasmalogen. In this final step, 1-alkyl 2-acylglycerol 3-phosphoethanolamine is desaturated to produce as 1-alkenyl 2-acylglycerol 3-phosphoethanolamine, i.e., plasmalogen. Figure 12.44 Formation of 1-alkenyl 2-acylglycerol 3-phosphoethanolamine, plasmalogen. A variety of plasmalogens are produced by replacing ethanolamine with choline or serine. Ethanolamine plasmalogen is richly present in the myelin sheath around nerve fibers. Choline plasmalogen is abundant in cardiac tissue and serine plasmalogen is found in the retina and white matter of the eye. 12.11.2 Interconversion of glycerophospholipids. Various types of interconversion among glycerophospholipids can also occur. For example, I. Decarboxylation of serine residue of phosphatidylserine gives to phosphatidylethanolamine. Figure 12.45 Decarboxylation of phosphatidylserine to form phosphatidylethanolamine. 2. Addition of 3 methyl groups to the ethanolamine residue of phosphatidylethanolamine converts it into phosphatidylcholine. Figure 12.46 Methylation of phosphatidylethanolamine to form phosphatidylcholine. 12.11.3 Degradation of glycerophospholipids. Glycerophospholipids are hydrolyzed by phospholipases. The different phospholipases are phospholipase A1, phospholipase A2, phospholipase B, phospholipase C and phospholipase D. Each phospholipase acts on a specific bond. Phospholipase A1, it hydrolyzes the ester bond at position 1 of the phospholipid. 2-phospholipase A2, it hydrolyzes the ester bond at position 2 of the phospholipid. It converts the phospholipid into a lysophospholipid. It is present in pancreatic juice and is also found in snake and bee venoms. It causes the release of arachidonic acid, the precursor of many eicosanoids, by acting on phosphatidylinositol. 3-phospholipase B, it acts on lysophospholipids. It removes the fatty acid from position 1 of the lysophospholipid. 4-phospholipase C, it acts as a sphingomyelinase and is involved in the catabolism of sphingomyelin. It is present in hepatic lysosomes and also found in alpha-toxin of Clostridia as well as in other bacilli. V-phospholipase D, it acts on phosphatidylcholine and generates phosphatidic acid and choline. Its action on phosphatidic acid releases diacylglycerol. Phospholipase D is also involved in signal transduction. 12.11.4 Synthesis of sphingospholipids. Sphingomyelin is composed of fatty acid, phosphoric acid, nitrogenous base, and sphingosine. It is synthesized from ceramide and phosphatidylcholine. Ceramide is acyl sphingosine. Figure 12.47 Synthesis of sphingomyelin. 12.11.5 Degradation or catabolism of sphingomyelin. Sphingomyelin is catabolized by lysosomal sphingomyelinase, a type of phospholipase C, into ceramide and phosphorylcholine. The ceramide is then cleaved by ceramidase into sphingosine and free fatty acid. The ceramide and sphingosine are involved in the regulation of signal transduction pathways by following two activities. I influences the activity of protein kinase C through phosphorylation of its protein substrates. 2. They also stimulate the process of apoptosis. Figure 12.48 Degradation of sphingomyelin. 12.12 Metabolism of glycolipids, glycosphingolipids. Glycolipids are complexes of carbohydrates and lipids. They produce sugar, fatty acid, and sphingosine on hydrolysis. They are the derivatives of ceramide. They differ from sphingomyelins in the respect that they do not contain phosphoric acid and the role of the polar head is provided by monosaccharide or oligosaccharide attached directly to ceramide by an O-glycosidic linkage. The type of glycosphingolipid is determined by the number and type of carbohydrate moieties. Just like phospholipids, they are also the essential components of all membranes in the body, but they are more abundant in nerve tissue. They are mainly found on the outer leaflet of the plasma membrane, in order to establish proper communication with the extracellular environment. Being part of many membrane receptors and transporters, they are actively involved in the regulation of cellular interactions such as adhesion and recognition along with growth, development, and apoptosis. Clinical aspects. Glycolipids are antigenic in nature and they are responsible for the generation of ABO blood group antigens. One of the aspects of ABO blood grouping is based on differences in the type of glycoprotein present on the surface of red blood cells. Type A individuals have type A glycoproteins, type B individuals have type B glycoproteins, type AB individuals have both and type O individuals have none. 12.12.1 Synthesis of glycosphingolipids. The de novo synthesis of glycosphingolipids starts at the endoplasmic reticulum and continues in the Golgi apparatus by sequential addition of glycosyl monomers transferred from UDP sugar donors to the acceptor molecule. The main enzymes involved are specific glycosyl transferases. Figure 12.49 Synthesis of glycosphingolipids, NANA, N-acetylneurominic acid, CMP, cytidine monophosphate, UDP, uridine diphosphate. 12.12.2 Synthesis of sulfolipids, sulfatides. The addition of the sulfate group to glycolipid gives sulfolipids. For example, sulfatide galactocerebroside 3-sulfate is formed by the addition of the sulfate group to the 3-hydroxyl group of the galactose of galactocerebroside by sulfatransferase. The sulfate group is donated by 3-phosphoadenosine 5-phosphosulfate, PAPS. 12.12.3 Degradation of glycosphingolipids. The catabolism of glycosphingolipids follows the catabolic pattern of glycosaminoglycans, during which glycosphingolipids are internalized by endocytosis. All the catabolic enzymes are found in lysosomes, which fuse with the endocytotic vesicles. The degradative process occurred on the rule of last on, first off. By this rule, the group added in last during synthesis is removed first. 12.13 Lipid storage diseases, lipidoses. These are a group of inherited metabolic disorders in which harmful amounts of lipids accumulate in various tissues and cells of the body. These are subtypes of lysosomal storage diseases. A group of acid hydrolases, found in lysosomes, are responsible for the hydrolysis of a variety of complex compounds. Deficiency of the certain lysosomal enzyme causes the accumulation of respective substrates in the affected cell. Following are the important types of lipid storage diseases. 1. Neutral glycosphingolipidoses. I. Gaucher's disease. It is the most common lysosomal storage disease. It occurs due to a deficiency of the enzyme acid beta-glucosidase, glucocerebrosidase or glucosylceramidase. It is characterized by the accumulation of glucocerebrosides in cells of the macrophage monocyte system, particularly in the liver and spleen. Other features include erosion of long bones, moderate anemia, and mental retardation in infants. Neurons are rarely affected. Treatment is by enzyme replacement therapy. 2. Niemann-Pick disease. It is an autosomal recessive disorder characterized by abnormal deposits of lipids in the body. This disease exists in two forms, type A and type B. Type A is infantile and more severe, in which sphingomyelinase activity is less than 1%. There are markedly increased lysosomal lipids in the spleen and liver. Another characteristic feature is the cherry red macula of the eye. Infants experience rapid and progressive neurodegeneration and death may occur in ages. Type B is less severe, in which sphingomyelinase activity is up to 10% of the normal. There is no damage to the neural tissues but the liver, lungs, spleen, and bone marrow are affected. Type C of Niemann-Pick disease is also found, which is characterized by an inability of the body to transport cholesterol and other fatty substances inside of cells. This leads to the abnormal accumulation of these lipids within various tissues of the body including brain tissue. 3. Fabry's disease. It is an X-linked inheritance disorder, due to the deficiency of enzyme alpha-galactosidase. It is characterized by the accumulation of globosides. Clinical symptoms include skin rash, purplish papules, progressive renal and heart failure, and death may occur by 5 years of age. It can be treated by enzyme replacement therapy. 2. Gangliosidosis. Tay-Sachs disease. It is due to a deficiency of enzyme hexosaminidase A, which results in the accumulation of GM2 gangliosides. The incidence rate is 1 in 6,000 live births. Clinical symptoms are mental retardation, blindness, cherry red spot in the macula, muscular weakness, progressive deterioration, and death may occur by 3 to 4 years of age. 2. Sandoff's disease. This disorder is due to the deficiency of enzyme hexosaminidase A and B. Accumulated lipids are globosides. Clinical symptoms are neurological deficit and mental retardation. 3. Generalized gangliosidosis. It is due to a deficiency of enzyme beta-galactosidase. The accumulated lipid is ganglioside, GM1. Clinical symptoms are mental retardation, hepatosplenomegaly, skeletal deformities, foam cells in bone marrow, and cherry red macula in the retina of the eye. 3. Mucolipidosis. I cell disease or inclusion cell disease, mucolipidosis 2. It is a rare inherited metabolic disorder due to deficiency of the enzyme UDP-N-actyl glucosamine 1-phosphotransferase. It is characterized by coarse facial features, skeletal abnormalities, and mental retardation. The symptoms of I cell disease are similar to but more severe than those of Hurler syndrome. 2. Pseudo-Hurler polydystrophy. It is also referred to as mucolipidosis 3, and is a lysosomal storage disease closely related to I cell disease, ML2. This disorder is called pseudo-Hurler because it resembles a mild form of Hurler syndrome. 4 Disorders of neutral lipids. Wallman disease. It is a rare genetic disorder caused by the complete absence of the enzyme lysosomal acid lipase. It is associated with the accumulation of cholesterol esters and triacylglycerols in body cells. 2 Cholesterol ester storage disease. Its cause is the same as Wallman disease, but accumulated lipid is only cholesterol esters. 5 Leukodystrophies. Krabs disease. It is due to the deficiency of beta-galactosidase, galactosylceramidase. Accumulated lipid is galactosylceramide. Clinical symptoms are severe mental retardation, deafness, blindness, the total absence of myelin in CNS, and deposition of globoid bodies in white matter. 2 Metachromatic leukodystrophy. It is due to a deficiency of the enzyme aryl sulfatase. The accumulated lipid is 3-sulfagalactosylceramide. Clinical symptoms are mental retardation and psychological disturbances in adults, demyelination, neurological deficit, difficulty in speech and optic atrophy, progressive paralysis, and dementia in infantile form. Nerves stain yellowish-brown with crescel violet. 3 Farber's disease. Enzyme deficiency is ceramidase. The accumulated lipid is ceramide. Clinical symptoms are hoarseness, dermatitis, subcutaneous nodules of lipid-laden cells, tissues showing granulomas, skeletal deformities, painful and progressive joint deformity, mental retardation, and fatal in early life. 12.14 Metabolism of eicosanoids. Eicosanoid is a group of biologically active substances derived from 3,20-carbon polyunsaturated fatty acids, dehomogammalinolenic acid, arachidonic acid and eicosapentaenoic acid. They include prostanoids, prostaglandins, prostacyclins, and thromboxanes, leukotrienes and lipoxins. All eicosanoids are derived from arachidonic acid. The pathways leading to the eicosanoids formation are collectively known as the arachidonic cascade. There are 2 major pathways within the cascade: the cyclooxygenase pathway for the synthesis of prostaglandins, prostacyclins, and thromboxanes, and the lipoxygenase pathway for the synthesis of leukotrienes and lipoxins. 12.14.1 Synthesis of prostaglandins and thromboxanes. Arachidonic acid, 20:4, 5,8,11,14 eicosapentaenoic acid, is the precursor for most of the prostaglandins in humans. It is present in the cell membrane in its esterified form. It is derived directly from dietary sources or indirectly released from membrane phospholipids through the activation of cellular phospholipases, example phospholipase A2, in response to many signals such as an increase in calcium concentration. The very first prostaglandin synthesized in the cyclooxygenase pathway is PGG2 by the enzyme PGH2 synthase or prostaglandin endoperoxide synthase. PGH2 synthase is a heme-containing dioxygenase, bound to membranes of the endoplasmic reticulum. This enzyme has the following 2 catalytic activities. 1 Fatty acid cyclooxygenase, COX, need oxygen and exist in 2 isomeric forms, COX-1 which is constitutive and COX-2 which is inducible. 2 Peroxidase, need reduced glutathione. PGG2 is converted to PGH2 by peroxidase in the presence of glutathione. PGH2 serves as the immediate precursor for the synthesis of several prostaglandins, including prostacyclins and thromboxanes. It is converted to them by respective cellular synthase. Figure 12.50 Outline of synthesis of eicosanoids from arachidonic acid, showing the synthesis of prostaglandins, prostacyclins, and thromboxanes by cyclooxygenase pathway and synthesis of leukotrienes by lipoxygenase pathway, PG, prostaglandin, PGI, prostacyclins, TX, thromboxane, 5-hopit, 5-hydroxyperoxyeicosapentaenoic acid, LT, leukotriene. 12.14.2 Inhibition of PGS synthesis. Synthesis of PGS as well as TXS can be inhibited by several compounds such as corticosteroids, example cortisol, prevent the formation of arachidonic acid by inhibiting the enzyme phospholipase A2. Similarly, anti-inflammatory drugs inhibit the synthesis of prostaglandins, prostacyclins, and thromboxanes by blocking the action of cyclooxygenase. Aspirin irreversibly inhibits cyclooxygenase, Other NSAIDs like indomethacin and phenylbutazone can also inhibit cyclooxygenase. Figure 12.51 Synthesis of prostaglandins and thromboxanes of series 2 from arachidonic acid, HHT, hydroxyheptade catrienoate, PG, prostaglandin, PGI, prostacyclin, TX, thromboxane. Note, both of these activities are attributed to the cyclooxygenase enzyme i.e., prostaglandin H synthase. Similar conversions occur in prostaglandins and thromboxanes of series 1 and 3. 12.14.3 Synthesis of leukotrienes. Synthesis of leukotrienes mainly takes place in neutrophils and to some extent also in eosinophils, monocytes, basophils, and mast cells. Lipoxygenase, LO, is the main enzyme of leukotriene synthesis. It is an arachidonic acid oxygenating enzyme which is dioxygenase in nature. There is a family of lipoxygenases that differ in the position of the double bond on the arachidonic acid molecule at which oxygen attack initially occurs, example position 5, 12, 15. 3 lipoxygenases are present in human cells, 5 lipoxygenase, 12 lipoxygenase, and 15 lipoxygenase. Only 5 lipoxygenase, neutrophil leukocytes, gives leukotrienes. Leukocytes contain 5 lipoxygenase, which converts arachidonic acid to 5-heptade. This is converted to an epoxide i.e., LTA4. The subscript number 4 refers to the presence of 4 double bonds in the leukotriene. 3 of the double bonds, 7, 9, 11, are conjugated to form a triene. 2 metabolic routes are available to LTA4. One is the addition of water to form LTB4 using a hydrolase enzyme. Alternatively, glutathione can combine with C6 of LTA4 to form LTC4 by glutathione S-transferase, LTC4 synthase. Subsequently, the glutamate residue of glutathione can be removed from LTC4 by the action of gamma-glutamyl transpeptidase to give LTD4. Finally, the glycine residue is removed from LTD4 to create the cysteine derivative i.e., LTE4 by the enzyme dipeptidase. Primary sites of leukotrienes biosynthesis. The distribution of 5-LO is limited to several cells, example neutrophils, eosinophils, monocytes, macrophages, mast cells, basophils, and B lymphocytes. The export of LTA4 from cells that can actively synthesize it enables a much broader range of cells to act as LTS secretors. Secondary sites of leukotrienes biosynthesis. Since LTA4 hydrolase and glutathione S-transferase, LTC4 synthase, are widely distributed among different cell types, so it is not necessary that all enzymes of leukotriene synthesis must be in the same cellular location for LT biosynthesis to proceed. Biosynthesis of leukotrienes by cell-cell interaction. Transcellular biosynthesis. The locations at which the LTS are synthesized are determined by the cellular distribution of the enzymes controlling each stage of the biosynthetic pathway. Arachidonic acid products can pass from one cell type to another, and different cell types can operate with each other to generate eicosanoids. Cells that are not capable of generating a particular class of eicosanoid can produce these mediators from intermediates generated in other cells, thus expanding the array and quantities of eicosanoids produced at sites of inflammation. Figure 12.52 Biosynthesis of leukotrienes and lipoxins by cell-cell interaction. Activated neutrophils generate LTB4 from arachidonic acid-derived LTA4 by the action of 5-lipoxygenase, but they do not possess glutathione S-transferase or LTC4 synthase activity and consequently do not produce LTC4. In contrast, platelets cannot form LTC4 from endogenous substrates because of the absence of 5-lipoxygenase, but they can generate LTC4 from neutrophil-derived LTA4, AA, arachidonic acid, LT, leukotriene, source, Elsevier 2005. 12.14.4 Degradation of eicosanoids. All the eicosanoids are metabolized rapidly. Their degradation occurs in the lungs and liver. The two enzymes concerned with their breakdown process are, namely 1,5-alpha-hydroxy-PG dehydrogenase and 13-PG reductase, which convert the hydroxyl group at C15 to keto group, then to C13 and C14 dihydroderivative. Clinical aspect. leukotrienes contribute to the pathophysiology of asthma by causing pulmonary airway obstruction by smooth muscle contraction, increased mucosal secretion and accumulation, and increase in infiltration of inflammatory cells. 12.15 Fatty liver. Fatty liver or fatty liver disease is an abnormal reversible condition characterized by the accumulation of large amounts of fat in hepatocytes. It is a clinical syndrome encompassing a wide range of fatty liver disease and become a risk for cirrhosis and cancer of the liver. Most of the major lipids are synthesized and catabolized in the liver. Triglycerides are synthesized in the liver and are transported out of the liver as VLDL. Lipotropic factors are the compounds required for the transport of lipids out of the liver. Some phospholipids also have a role in the prevention of fatty liver. The liver is the site for several pathways of lipid metabolism. Normally, the triglyceride content of the liver is not more than 5% of liver weight. When it exceeds 5%, the condition is known as fatty liver. Excessive fat deposition in the liver may cause inflammation of liver cells. Inflammation of liver cells may lead to their destruction. This may be followed by the formation of scar tissue in the liver, fibrosis. Extensive replacement of liver cells by fibrous tissue results in cirrhosis of the liver. 12.15.1 Central role of the liver in lipid transport and utilization. 1. It facilitates the digestion and absorption of lipids by the production of bile, which contains cholesterol and bile salts synthesized within the liver by the uptake of lipoprotein cholesterol. 2. Liver has an active enzyme system for the synthesis and oxidation of fatty acids and the synthesis of triacylglycerols and phospholipids. 3. It plays an integral part in the synthesis of and metabolism of plasma lipoproteins. 4. It converts fatty acids into ketone bodies. Figure 12.53 Role of liver in lipid transport and utilization. 2.15.2 Role of liver in TAG and fatty acid metabolism. Uptake. After a meal, the liver takes up about 30% of the free fatty acids and most of the absorbed fats. Synthesis. The liver converts part of the absorbed sugar into TAG. Free fatty acids that are produced from hydrolysis or after the feeding of fats is converted into TAG. Mobilization. TAG is mobilized from the liver into the blood in the form of VLDL. Oxidation. Free fatty acids are oxidized by the liver to supply energy. Ketogenesis. During starvation, ketone bodies are synthesized in the liver and released into the blood to extrahepatic tissues to serve as an alternative source of energy. 2.15.3 Types of fatty liver disease. Following are the important types. 1. Alcoholic liver disease, ALD. It is due to significant alcohol consumption, greater than 21 drinks/week for males and greater than 14 drinks/week for females. 2. Non-alcoholic fatty liver disease, NAFLD. It is characterized by steatosis without hepatocyte injury. 3. Non-alcoholic steatopatitis, NASH. It is characterized by steatosis with inflammation and hepatocyte injury with or without fibrosis. 4. Non-alcoholic cirrhosis, 60% of cryptogenic. There is irreversible liver damage caused by cirrhosis. Cryptogenic chronic hepatitis is a disease that is unexplained by conventional clinical, laboratory and histological findings, and it can progress to cirrhosis, develop hepatocellular carcinoma, and require liver transplantation. 2.15.4 Causes of fatty liver. Fatty liver may be caused by obesity, diabetes mellitus, alcohol abuse, severe protein deficiency, deficiency of essential fatty acids, hepatotoxic chemicals, and drugs. Imbalance in the rate of TAG synthesis and export cause fatty liver. Synthesis of TAG is regarded as an immediate stimulus for the formation and secretion of VLDL. As TAG does not normally accumulate in the liver under this condition, it must be inferred that it is transported from the liver in VLDL as rapidly as it is synthesized. Figure 12.54 Biochemical mechanisms causing fatty liver. Factors that enhance both the synthesis of triacylglycerol and secretion of very low-density lipoproteins, VLDL. Well-fed state. A carbohydrate-rich diet, especially fructose, leading to high rates of lipogenesis and esterification of fatty acids. High levels of circulating free fatty acids. Ingestion of ethanol. Presence of a high insulin/glucagon ratio which enhances fatty acid synthesis and esterification and inhibits their oxidation. Table 12.7 General causes of fatty liver. Nutritional factors. Endocrine factors. High-fat diet. High-carbohydrate diet. Low-protein diet. Deficiency of vitamins, vitamin E, B12, folic acid, pyridoxine, etc. Starvation. Deficiency of lipotropic factors. Obesity. Ethanol. Excessive consumption of certain substances, cysteine, thiamine, etc. Deficiency of insulin. Excess of certain hormones. Thyroid, catecholamines, glucocorticoids, ACTH. Female sex hormones etc. Toxic factors. Bacterial toxins. Drugs, aspirin, tetracycline, valproic acid, etc. Chemical poisons, CCl4, DDT, phosphorus, lead, orotic acid, arsenic, etc. Hypoxic factors, anemia and congestive. Heart failure. Disorders of lipid metabolism. Certain lipid storage diseases. Hyperlipoproteinemias. Abetalipoproteinemia. 12.15.5 Alcohol and fatty liver. Fatty liver is commonly associated with alcohol or metabolic syndrome but may be due to many other causes. Figure 12.55 Signs of metabolic syndrome, HDLC, high-density lipoprotein cholesterol, TG, triglyceride, PCOS, polycystic ovarian syndrome, NASH, non-alcoholic steatohepatitis. Alcohol use is one of the leading causes of the global burden of disease and injury. Alcoholic liver disease, a direct result of chronic alcohol abuse, insidiously destroys the normal functions of the liver. The end result of the disease, cirrhosis, culminates in a dysfunctional and diffusely scarred liver. Chronic alcoholism is the most important cause of fatty liver and liver cirrhosis. With a caloric value of 7 kcal/g, alcohol, ethanol, is rich in energy. After ingestion of alcohol, oxidation of glucose and fatty acids decreases, and alcohol becomes the preferred source of energy. Since fatty acids are not oxidized, they are esterified with glycerol to form triglycerides. Increased synthesis of triglycerides in the liver leads to their accumulation in the liver. This causes fatty liver especially when lipotropic factors are deficient. Main effects of alcohol on the liver. Reduction in liver production of glucose leads to hypoglycemia. Brain deprived of proper nourishment. Weakness, nervousness, excessive sweating, headache and tremors. Finally, fatty liver. Alcoholic fatty liver is the first stage of alcoholic liver disease, ALD, which is caused by alcoholism and ultimately leads to cirrhosis. Following metabolic changes occur in alcoholic fatty liver. 1. The fat accumulation in the liver is caused by a combination of impaired fatty acid oxidation and increased lipogenesis, which is thought to be due to changes in the NADH/NAD+ redox potential in the liver, and also to interference with the action of transcription factors regulating the expression of the enzymes involved in the pathways. 2. Oxidation of ethanol by alcohol dehydrogenase leads to excess production of NADH, which competes with reducing equivalents from other substrates, including fatty acids, for the respiratory chain. This inhibits their oxidation and causes increased esterification of fatty acids to form triacylglycerol, which results in a fatty liver. 3. Oxidation of ethanol leads to the formation of acetaldehyde, which is oxidized by aldehyde dehydrogenase to produce acetate. 4. The increased NADH/NAD+ ratio also causes increased lactate/pyruvate ratio causes hyperlactic acidemia, which decreases the excretion of uric acid and results in the exaggeration of symptoms of gout. 5. Some metabolism of ethanol takes place via a cytochrome P450-dependent microsomal ethanol oxidizing system, MEOS, involving NADPH and O2. This system increases activity in chronic alcoholism and may account for the increased metabolic clearance in this condition. 6-ethanol also inhibits the metabolism of some drugs like barbiturates, by competing for cytochrome P450-dependent enzymes. 7. In some Asian populations and Native Americans, alcohol consumption results in increased adverse reactions to acetaldehyde owing to a genetic defect of mitochondrial aldehyde dehydrogenase. Figure 12.56 Metabolism of ethanol, ADH, alcohol dehydrogenase, ALDH, acetaldehyde dehydrogenase, NAD, nicotinamide adenine dinucleotide, MEOS, microsomal ethanol oxidizing system, ROS, reactive oxygen species. 12.15.6 Non-alcoholic fatty liver disease, NAFLD. It is the most common liver disorder worldwide. It occurs when an accumulation of lipids in the liver becomes chronic, then inflammatory and fibrotic changes may develop leading to non-alcoholic steatohepatitis, NASH, which can progress to liver diseases including cirrhosis, hepatocarcinoma, and liver failure. Fatty livers fall into two main categories. The first type is associated with raised levels of plasma-free fatty acids resulting from the mobilization of fat from adipose tissue or the hydrolysis of lipoprotein triacylglycerol by lipoprotein lipase in extrahepatic tissues. The production of VLDL does not keep pace with the increasing influx and esterification of free fatty acids, allowing triacylglycerol to accumulate. This occurs during the following two conditions: I. Starvation and the feeding of high-fat diets. The ability to secrete VLDL may also be impaired. 2. In uncontrolled diabetes mellitus and ketosis, fatty infiltration is sufficiently severe to cause enlargement of the liver with possible liver dysfunction. The second type of fatty liver is usually due to a metabolic block in the production of plasma lipoproteins, thus allowing triacylglycerol to accumulate. Theoretically, the lesion may be due to I. A block in apolipoprotein's synthesis, or an increase in its degradation before it can be incorporated into VLDL. 2. A block in the synthesis of the lipoprotein from lipids and apolipoproteins. 3. A failure in the provision of phospholipids that are found in lipoproteins. 4. A failure in the secretory mechanism itself. 12.15.7 Lipotropic, adipokinetic, or lipotrophic agents. They tend to prevent the accumulation of, or remove abnormal amounts of lipids, in a tissue or organ, particularly in the liver. 1. Choline. It is the most important lipotropic factor. It is needed for the synthesis of glycerophospholipid, example lecithin. Lecithin is a component of lipoproteins that helps in the transport of lipids from the liver. Lecithin is also the major component of membranes. Choline also increases the rate of free fatty acid oxidation in the liver. 2. Methionine and betaine, involved in the synthesis of choline. 3. Vitamin E and selenium, they prevent lipid peroxidation. 4. Carnitine, it enhances free fatty acid oxidation. 5. Inositol, it is also involved in the synthesis of phospholipids, example cephalin. 6. Others, essential free fatty acids, example linoleic acid, and vitamins, folic acid, pyridoxine, pantothenic acid, have a significant role in the prevention of fatty liver as fatty infiltration of the liver is seen in their deficiencies. Figure 12.57 Appearance of a normal, fatty, fibrotic, and cirrhotic liver. The antibiotic purimycin, ethionine, alpha-aminogamma-mercaptobutyric acid, carbon tetrachloride, CCl4, chloroform, phosphorus, lead and arsenic all cause fatty liver and a marked reduction in the concentration of VLDL in rats. Choline will not protect the organism against these agents but appears to aid in recovery. The action of carbon tetrachloride probably involves the formation of free radicals causing lipid peroxidation. Some protection against this is provided by the antioxidant action of vitamin E supplemented diets. The action of ethionine is thought to be caused by a reduction in the synthesis of ADP. Orotic acid also causes fatty liver. It is believed to interfere with glycosylation of the lipoprotein, thus inhibiting release, and may also impair the recruitment of triacylglycerol to the particles. Added vitamin E or a source of selenium has a protective effect by combating lipid peroxidation. 12.16 Dyslipidemia/dyslipoproteinemia. Dyslipoproteinemia, also referred to as dyslipidemia, encompasses a range of disorders of lipoprotein lipid metabolism that include both abnormally high and low lipoprotein concentrations, as well as abnormalities in the composition of these lipoprotein particles. Dyslipidemias are clinically important because of their role in the pathogenesis of the cardiovascular disease, CVD, including coronary artery disease, CAD, cerebrovascular disease, peripheral vascular disease and renal disease. Thus, the term dyslipidemia is broader than the term only hyperlipidemia, which focuses solely on the elevated concentrations of lipoproteins. Dyslipidemias are classified into primary, due to inherited defects, and secondary types. A. Primary dyslipidemias. All primary dyslipidemias are due to a defect at a stage in lipoprotein formation, transport, or degradation. They have inherited defects in lipoprotein metabolism leading to the primary condition of either hypo or hyperlipoproteinemia. I. Primary hypolipoproteinemias. It is of the following two types. 1. Abetalipoproteinemia. It is an autosomal recessive disorder that interferes with the normal absorption of fat and fat-soluble vitamins from food. It is caused by a mutation in microsomal triglyceride transfer protein resulting in deficiencies in the apolipoproteins B48 and B100, which are used in the synthesis and exportation of chylomicrons and VLDL respectively. So, no chylomicrons, VLDL, or LDL are formed because of fault in the filling of ApoB with lipid. This disorder is quite rare and characterized by reduced blood acylglycerols, high acylglycerols in the intestine and liver along with intestinal malabsorption. The problem of early death can be avoided by the administration of large doses of fat-soluble vitamins, particularly vitamin E. 2. Familial alpha-lipoprotein deficiency. It is also known as Tang-Ear disease, fish eye disease, or ApoAI deficiencies. It is a rare inherited disorder, autosomal recessive disorder, characterized by a severe reduction in the amount of high-density lipoprotein, HDL. ABCA1 transporter is defective due to mutations to chromosome 9q31. There is a tendency to develop hypertriacylglycerolemia and atherosclerosis. 2. Primary hyperlipoproteinemias. It includes the following subtypes. 1. Familial lipoprotein lipase deficiency, type I. Type Ia, it is due to a deficiency of lipoprotein lipase, LPL, or altered apolipoprotein C2, resulting in elevated chylomicrons, the particles that transfer fatty acids from the digestive tract to the liver. 2. Type IB, it is due to a deficiency of apolipoprotein C2, which is a lipoprotein lipase activator. 3. Type IC, it is characterized by chylomicronemia due to a circulating inhibitor of lipoprotein lipase. The disorder of type I hyperlipoproteinemia usually appeared in childhood with eruptive xanthoma and abdominal colic. As the disease progressed, many complications appeared such as retinal vein occlusion, acute pancreatitis, steatoses, organomegaly and lipemia retinalis. 2. Familial hypercholesterolemia. It is the most common form of hyperlipoproteinemia, and is further classified into types IIA and IIB, depending mainly on whether elevation in the triglyceride level occurs in addition to LDL cholesterol. Type IIA, this may be sporadic, due to dietary factors, polygenic, or truly familial as a result of a mutation either in the LDL receptor gene on chromosome 19 or the ApoB gene. The familial form is characterized by tendon xanthoma, xanthelasma, and premature cardiovascular disease. 2. Type IIB, the high VLDL levels are due to the overproduction of triacylglycerols, acetyl-CoA, and an ApoB 100. This condition may also be due to decreased clearance of LDL. 3. Familial type 3 hyperlipoproteinemia, it is also known as broad beta disease, remnant removal disease, or familial dysbeta-lipoproteinemia. It is caused by a deficiency in remnant clearance by the liver due to abnormality in ApoE. The isoforms E3 and E4 are absent and patients have only E2, which is unable to react with the E receptor. The main features are an increase in chylomicron and VLDL remnants, hypercholesterolemia, tuberous xanthomas, and striae palmaris. Increased risk for atherosclerosis and peripheral vascular disease. 4. Familial hypertriacylglycerolemia, type 4. It is an autosomal dominant condition occurring in approximately 1% of the population. It is due to the overproduction of VLDL, often associated with glucose intolerance and hyperinsulinemia. It is characterized by raised cholesterol levels with VLDL concentration. LDL and HDL may be less than normal. There are many other conditions found along with this disorder, such as coronary heart disease, type 2 diabetes mellitus, obesity, alcoholism, and administration of progestational hormones. 5. Familial hyperalpha-lipoproteinemia, it is an autosomal dominant disorder, exact molecular etiology is unknown. It is modest to marked elevations in HDL and ApoAI, selective increase in the synthesis of ApoAI in some groups of patients. It is associated with longevity and showed protection against atherosclerotic vascular disease in epidemiologic studies. 6. Hepatic lipase deficiency, it is an autosomal recessive disorder. It is caused by mutations in the LIPC gene. This gene is responsible for the expression of an enzyme called hepatic lipase. The lack of enzyme hepatic lipase causes the accumulation of large triacylglycerol-rich HDL and VLDL remnants. Patients present xanthomas and associated coronary heart disease. 7. Familial lecithin cholesterol acyltransferase, LCAT, deficiency, it is an autosomal recessive disorder caused by mutations of the LCAT gene resulting in LCAT deficiency. The clinical manifestations of LCAT deficiency are likely due to a defect in LCAT-mediated cholesterol ester formation and, therefore, accumulation of unesterified, free, cholesterol in certain tissues, such as the cornea, kidneys and erythrocytes. Patients may present with HDL deficiency, corneal opacification, hemolytic anemia, hypertension, hypertriglyceridemia, and proteinuria. 8. Familial lipoprotein A, excess, lipoprotein A, or Lp(a), is a subclass of lipoprotein, consists of 1 mole of LDL attached to 1 mole of ApoA. The structure of lipoprotein A is similar to plasminogen and tissue plasminogen activator, TPA, and it competes with plasminogen for its binding site, leading to reduced fibrinolysis. Also, because Lp(a) stimulates the secretion of plasminogen activator inhibitor 1, Pfau, it leads to thrombogenesis. Lp(a) also carries cholesterol and thus contributes to atherosclerosis. B. Secondary dyslipoproteinemias, acquired hyperlipidemias. These often mimic primary forms of hyperlipoproteinemias and can have similar consequences. They may result in an increased risk of premature atherosclerosis or, when associated with marked hypertriglyceridemia, may lead to pancreatitis and other complications of chylomicronemia syndrome. The most common causes of acquired hyperlipidemia are 1. Diabetes mellitus. 2. Use of drugs such as thiazide diuretics, beta blockers, and estrogens. 3. Hypothyroidism. 4. Kidney failure. 5. Nephrotic syndrome. 6. Alcohol consumption. 7. Some rare endocrine disorders and metabolic disorders. Table 12.8 Secondary causes of dyslipoproteinemias. Defect in dyslipoproteinemia. Associated conditions. Hypercholesterolemia. Hypothyroidism, obstructive liver disease, nephrotic syndrome, drugs. Progestogens, cyclosporin, thiazides. Hypertriglyceridemia. Obesity, diabetes mellitus, pregnancy. Chronic renal failure, CRF, alcohol, stress. Sepsis, acute hepatitis, systemic lupus. Erythematosus, SLE, drugs, estrogen. Beta blockers, steroids, acid resins, thiazides. Low HDL. Type 2 DM, rheumatoid arthritis. Malnutrition, obesity, cigarette smoking. Beta blockers. 12.16.1 Complications of hyperlipoproteinemias. Dyslipoproteinemia is involved in the origin of arteriosclerosis by changing the architecture of the coronary artery wall and therefore represents an important factor in the development of coronary artery disease, CAD, heart attack, stroke, and premature death. The concern arises because an elevated concentration of lipoproteins can accelerate the development of atherosclerosis and its complications like angina, stroke, and myocardial infarction, MI. Studies have now shown that reducing lipoprotein levels diminishes the risk of MI. 1. Xanthelasma. These are sharply demarcated deposits of yellowish fat underneath the periorbital skin. 2. Atherosclerosis. It is a well-established complication of hyperlipoproteinemia. 3. Corneal arcus. It is due to lipid infiltration of the corneal stroma, around the iris of the eye. 4. Tendon xanthomas. These are due to the deposition of yellowish cholesterol-rich material in the extensor tendons of hands, feet, and patella. 5. Lipemia retinalis. It is characterized by hyperlipidemic vascular lesions giving whitish color to vessels. There is lipid infiltration into the retina causing a decrease in visual acuity. 6. Coronary heart disease, CHD. It is associated with premature coronary artery disease, in which the vessels become so narrow that the blood cannot pump to the heart properly. Early symptoms are chest pain and difficulty in breathing and eventually can cause a heart attack. 7. Thrombosis. Hyperlipidemia has been linked with increased stroke risk because of plaque formation. It is due to hyperlipidemia. The plaque lodges in the brain and prevent blood from flowing to the brain, resulting in cell death. An ischemic stroke, due to thrombosis, is the most common type of stroke, most often cerebral. 2.16.2 Complication of hypolipoproteinemias. 1. Coronary atherosclerosis. Due decrease in HDL leads to the accumulation of cholesterol in the intima of large arteries. 2. Yellow, orange, tonsillitis. It is a very rare condition due to decrease HDL, cholesterol esters are accumulated in the tonsils. 3. Depressed tendon reflexes. Decrease in HDL, cholesterol esters are accumulated in tendons of various muscles. 4. Recurrent peripheral neuropathies. These are due to the accumulation of oxidized lipids in the myelin sheath of peripheral nerves. Summary. Adipocytes, adipose tissue, are specialized for the synthesis and storage of triacylglycerol and for their mobilization into fuel molecules that are transported to other tissues by the blood. In the plasma, lipid exists in two forms, free fatty acids, FFAs, and lipoproteins. Adult man ingests about 60 to 150 g of lipids per day, of which 90% is normally TAG. The remainder of dietary lipids are made of cholesterol, cholesterol esters, phospholipids, and FFAs. Lipolysis is the catabolic aspect of lipid metabolism and describes the process by which fats are broken down by enzymes and water, hydrolysis. The major site of lipolysis is adipose tissue. The product of lipolysis are the free fatty acids and free glycerol. Both products leave the adipocyte. Normal fasting plasma free fatty acid level, 15-20 mg/dl, is increased by anti-insulin hormones, epinephrine, glucagon, cortisol, growth hormone, thyroxine, starvation and diabetes mellitus. The plasma free fatty acid level is decreased by insulin. Fatty acids are oxidized by many methods like oxidation, and omega oxidation. The oxidation of even carbon-saturated fatty acid occurs in three phases: I. Activation of the fatty acid, 2. Transport of fatty acyl-CoA to mitochondrial matrix, and 3. Repeated oxidation of acyl-CoA, in spiral fashion, to produce acetyl-CoA, FADH2 and NADH. Total moles of ADP produced from the complete oxidation of 1 mole of stearic acid equals 120. Peroxisomes are responsible for the oxidation of very long-chain and branched-chain fatty acids. Alpha oxidation is important in the catabolism of branched-chain fatty acids such as phytanic acid. Fatty acid synthetase complex is the main enzyme of fatty acid synthesis. The synthesis of unsaturated fatty acids takes place through the process of unsaturation of corresponding saturated fatty acids. Synthesis of triacylglycerol, TAG, takes place mainly in the liver and adipose tissue. Ketone bodies are a group of 3 water-soluble compounds containing the ketone group. They include acetone, acetoacetate, and hydroxybutyrate. Ketosis is a pathological condition that occurs when acetoacetate is produced faster than its catabolism and utilization. Diabetic ketoacidosis, DKA, is a state of inadequate insulin levels resulting in high blood sugar and accumulation of organic acids and ketones in the blood. Cholesterol is synthesized by using acetyl-CoA molecules as a precursor. Its biosynthesis mainly takes place in the liver but also in other tissues like skin, intestine, adrenal cortex, aorta, gonads, etc. The reduction of HMG-CoA to mevalonic acid by HMG-CoA reductase is the rate-limiting step of cholesterol biosynthesis. Cholesterol is transported in the blood as part of soluble complexes called lipoproteins. The normal blood cholesterol level is 140-199 mg/dl. Hypercholesterolemia is associated with atherosclerosis of vital arteries, causing cerebrovascular, coronary and peripheral vascular disease by narrowing and hardening of the arteries. Normal levels of HDL in male is 35-65 mg/dl and in female is 35-80 mg/dl. The total cholesterol/HDL ratio helps to estimate the risk of developing atherosclerosis. HDL is involved in reverse cholesterol transport, i.e., takes up cholesterol from peripheral tissues and returns it to the liver, thus HDL is termed as good cholesterol. The end product of cholesterol utilization is the bile acids, cholic acid and genodeoxycholic acid. Phospholipids are a group of specialized lipids performing a variety of functions, such as involvement in membrane structure and functions, blood clotting, and supply of arachidonic acid for the synthesis of prostaglandins and thromboxanes. Eicosanoid is a group of biologically active substances derived from 3,20-carbon polyunsaturated fatty acids, dehomogammalinolenic acid, arachidonic acid and eicosapentaenoic acid. Fatty liver or fatty liver disease is an abnormal reversible condition characterized by the accumulation of large amounts of fat, more than 5%, in hepatocytes. Alcoholic fatty liver is the first stage of alcoholic liver disease, ALD, which is caused by alcoholism and ultimately leads to cirrhosis. Lipotropic factors tend to prevent the accumulation of lipids in the liver. They include choline methionine, betaine, vitamin E, selenium, etc. Dyslipoproteinemia or dyslipidemia encompasses a range of disorders of lipoprotein metabolism that include both abnormally high and low lipoprotein concentrations, as well as abnormalities in the composition of these lipoprotein particles. All primary dyslipoproteinemias are due to a defect at a stage in lipoprotein formation, transport, or degradation. References. Exercise questions. For MCQ 1-5 see Part 1 and for MCQ 7-10 see Part 2 of this chapter. MCQ 11. A 20-month-old girl presented with rapid deterioration in her motor skills and the appearance of a distended belly. She was also unable to move her eyes from side to side. Physical and laboratory examination revealed hepatosplenomegaly, skeletal lesions, dry scaly skin, and lipid-laden foam cells having the appearance of wrinkled paper observed under the microscope. Which of the following diseases is the most likely present in this patient? A. Fabry disease. B. Gaucher disease. C. Crab disease. D. Niemann-Pick disease type B1. E. Tay-Sachs disease. MCQ 12. The autopsy of a man who died at the age of 65 years disclosed massive cardiomyopathy, cardiac storage of globotriacylceramide and limited cardiocytes. He suffered from stable angina pectoris for the last 15 years. During that time he developed progressive heart failure and repeated pulmonary thromboembolism. Which of the following lipid storage diseases is the cause of these clinical findings? A. Fabry disease. B. Gaucher disease. C. Crab disease. D. Niemann-Pick disease type A1. E. Tay-Sachs disease. MCQ 13. Which of the following lipid storage diseases may occur when ganglioside GM2 is not catabolized by lysosomal enzymes? A. Fabry disease. B. Gaucher disease. C. Crab disease. D. Niemann-Pick disease type A1. E. Tay-Sachs disease. MCQ 14. A 25-year-old woman presented with high-grade fever, 102 degrees Fahrenheit, due to a severe viral respiratory infection. Her temperature decreased after taking aspirin. Which of the following is the most likely mechanism of action of the drug taken by her to decrease the temperature? A. Activation of adenylate cyclase. B. Blockade of the action of exogenous viral. C. Inactivation of lipoxygenase. D. Inhibition of cyclooxygenase. E. Prevention of mast cell degranulation pyrogens. MCQ 15. A 22-month-old boy presented with generalized weakness and repeated episodes of vomiting and coma after several days of reduced food intake because of a minor febrile illness. Initially, he was given intravenous glucose. After 12 hours of fasting, lab investigations showed low levels of serum glucose and beta-hydroxybutyrate while free carnitine concentrations increased. Triglycerides containing only medium-chain fatty acids were fed, and the serum beta-hydroxybutyrate concentration increased to the normal range. Which of the following enzyme deficiencies is the most likely diagnosis in this patient? Acetyl-CoA carboxylase, carnitine palmitoyltransferase I, fatty acyl-CoA synthetase, medium-chain acyl-CoA dehydrogenase, beta-ketoacyl carrier protein synthase. End of Part 3 of 3 of Chapter 12. Thank you.